I'm Lawrence Cutchin. I'm a physician and was one of the first 3 AHEC directors in the North Carolina AHEC system. This morning I'm going to be using information, since I didn't gather the history myself, I'm using history from 2 books, Social Transformation of American Medicine by Paul Starr, and the second one is Bettering the Health of the People, and that book was written by 3 of my former teachers, Dr. Bill McClendon, Dr. Bill Blythe, and Dr. Floyd Denny. Before and during the 19th century, medical education left a lot to be desired. Most medical schools in those days were just physician-owned activities of a local practicing physician who brought in friends to give lectures. Course of study was usually less than a year. But Dr. Elliott brought it into the Harvard Corporation and made the following changes. Number 1, he hired full-time faculty for the first time. Number 2, he increased the course of study from 3 months to 9 months, and he increased the length of time before graduation from 2 years to 3 years. But the real changes came in 1893 when the Johns Hopkins School of Medicine was opened, and the 2 men that directed the changes there were Dr. William Osler and Dr. William Welch. The changes they made were really significant because they really are what we use today. First of all, for the first time, a college degree was required for admission to medical school. The course of study was increased from 3 to 4 years. They had full-time faculty, and they brought in people who had history of medical research for the days and experience in education. They built a hospital that was run as a companion organization with the medical school. And very important is they created postgraduate programs of study in specialty areas called residencies, and that's the model that we use today, and that it's not changed since that time. In 1906, the Council on Medical Education of the American Medical Association conducted a study of medical schools throughout the country. There were 160 schools present at that time. And they found that of the schools that they examined, and they examined all of them, they found that 82 of them were okay, and they could go on with it. 32 were not up to snuff, but could be improved. But they found that 32 were just beyond salvage and recommended they be closed. And they felt that it would be a good idea not to have the Medical Association put that information out, but to have it done by an independent party. So they petitioned the Carnegie Foundation to conduct a study on medical education similar to what they had done. And Dr. Abraham Flexner, who was not a physician, but he was an educator, was hired by the Carnegie Foundation to conduct the study and completed that study and published a report in 1910. And he found essentially the same things. He found that the top schools that they found could last and could serve well by continuing to improve along the lines of the Hopkins model. He found there were some that were not there yet but could be helped to achieve that, and he found the rest of them just should be closed down. And over the next 10 years, all of the substandard medical schools in the United States were closed. It's obvious to all of us that we've all benefited from the changes that were made. And in a summary, what Dr. Flexner recommended was that we bring medical education out of the community and into the university with full-time faculty who taught and did research as their major endeavors and practiced medicine to continue doing that. Medical practice and medical education improved significantly. The specialties were developed in full, and the frontiers were pushed back. And this armamentarium that we have today, which is magnificent, was developed over the first 50 years after the Flexner report came out. In 1930, the National Institute of Health was created and began to put money behind medical research. In 1948, the Hill-Burton bill was passed by Congress, and that provided money to build hospitals all over the United States because there were very few good hospitals in existence at that time. The mode of training was hospital-based, specialty-oriented. Primary care was really neglected. After the war, the National Institutes of Health poured a lot more money behind medical research. And by 1960, there was a hue and cry throughout the country because of access to medical care. Changes began to be thought about, and because at that time, primary care physicians, as a result of the medical education changes that had taken place, the number of primary care physicians in communities across the country had gradually diminished. And they were not being replaced, and people were very much concerned about that. The education for, if you wanted to be a primary care physician or family physician at that time, you could go right out and practice directly from medical school with no postgraduate training. In fact, there was a fellow in my class that did that in 1962 even. The pressure began to build to make a change in that. Well, North Carolina was relatively slow in responding, as were many other states in the country. After the Flexner report, there were only 2 medical schools left in existence in North Carolina. And those 2 were Wake Forest College, it was at that time, School of Medicine, and the other one was the 2-year medical school at the University of North Carolina in Chapel Hill. Both of those schools were approved by Flexner and were 2 of the schools that survived. The problem was that there was a great deal of concern whether these schools would be able to survive, because the students that took their initial training in a 2-year school then had to find a place to go for their last 2 years. And it was always difficult to find that because the schools were pretty well full with the students that they already had there. And to show you how bad things were in terms of education at the time, 57% of the young men who were called up for medical service at the beginning of the Second World War in North Carolina were turned down because of medical reasons. Dr. Walter Reese Berryhill was a driving force for the changes in medical education in North Carolina and expanding the school. Dr. Berryhill, first of all, was born in Charlotte, North Carolina. He attended undergraduate school at the University of North Carolina, graduated in 1921. When he finished in 23, he taught for a year, and then he entered the 2-year school in Chapel Hill, the 2-year School of Medicine. And when he completed that, he went to Harvard for his last 2 years of medical school and then stayed on at Boston City Hospital as a house officer for 2 years before returning to Charlotte to practice. After a couple of years in Charlotte, he was invited to come to Case Western Reserve University in Cleveland to be chief resident in internal medicine as the school there was beginning and needed good people on the faculty. He stayed for 2 years after that as a member of the faculty, and in 1933 he returned to Chapel Hill, and in Chapel Hill he came back as university physician and a faculty in the 2-year medical school. In 1937 he became assistant dean with Dr. McNider, who was the dean at the time, and remained assistant dean until 1941 when Dr. McNider was no longer dean and Dr. Berryhill became dean. Dr. Berryhill from the beginning had a vision in his mind of a 4-year medical school in North Carolina supported by the state that would be a medical school without walls, that it would reach out into communities, work with community hospitals, would become part of the training program for young physicians as they rotated with rotations out there. By doing that, get more doctors, get them in the right places. And that school also would train the ancillary personnel and serve as a consulting center for the state and a center for educational material to be shared with doctors and hospitals and other people throughout the state. To begin that process after becoming dean, and by the way, when he was appointed as dean, he was charged with the responsibility of expanding the school to a 4-year school. What he did was to pull together the leadership of medicine in North Carolina and formed a committee of physicians, and that committee of physicians looked at the situation. They looked at what Dr. Berryhill was interested in and added some things to it, but approved of it. Dr. Berryhill then presented the report to Governor Broughton, who shared it with the Board of Governors. What he did was to appoint a commission. It came to be known as the Poe Commission. The Poe Commission studied the situation and came back with recommendations and recommended that it be done. It was passed on to Governor Greg Cherry. Governor Cherry then appointed the state legislature, recommended that the 4-year school be created. Dr. Sanger, who was at that time the president of the University of Virginia, Sanger Commission was created. They came back with a recommendation that indeed there should be a 4-year medical school. There was a lot of discussion about where it should be placed, but the Poe Commission recommended that it be in Chapel Hill. and that it be a school that would serve as a central point for care for patients throughout the state of North Carolina, would serve as a referral center and a research center, and would reach out and develop a network of hospitals that would become part of the educational system for the University of North Carolina, for the state of North Carolina. As a result, the four-year medical school was constructed, and it was opened in 1952 after 2 years of planning and raising other funds. Money that had been provided for hospitals by the federal government through the Hill-Burton program helped, of course, with the hospital in Chapel Hill. It also had helped build other hospitals throughout the state of North Carolina, so the situation was a lot better by 1952. The four-year medical school was opened in 1952. In 1960s, it had really begun to be recognized as a center for research and medical education of the highest order. But the University of North Carolina faced the same kind of pressures within the state as experienced in other places. People were concerned for the fact that this seemed to be an ivory tower that was training just as specialists and not training primary care physicians for the general public. There was a lot of discussion about it nationwide. There was a lot of discussion about it in Chapel Hill, and they recognized the need. And Dr. Berryhill had always recognized that there was a need for this from the very beginning. But he also felt that, you can't sell from an empty wagon. He had to build a hub in Chapel Hill, which we could reach out and begin to develop the other parts of the program as well. He recognized very clearly that he had been charged with the responsibility of the four-year medical school, and the Sanger Commission had recommended that this be an outreach program as well. And so he began to think more about that, having come to the conclusion that he had accomplished the first part of what he was supposed to do. He resigned as dean in 1964 and took a 2-year sabbatical. And during that 2 years, he spent time visiting and learning about medical education in medical schools in Europe and all over the United States, and returned to America in '66. And when he came back, he found that in the meantime, there had been further discussions in Chapel Hill, and Dr. Ike Taylor, taking some medical school money, they had come up with the concept of developing an entity within the medical school that would be the site for reaching out and developing the relationships with hospitals across the state. That was the Division of Education and Research in Community Medical Care, which really was the beginning of AHEC. Several people were involved in the beginning. Glenn Pickard had just returned from an internship out of state, had come back to Chapel Hill to complete a residency at the University of North Carolina. I had completed medical school in '62, and after 2 years of residency had been in the Air Force for 2 years and had just returned to Chapel Hill in '64 to complete my residency training in the Med-Peds program. Dr. Bob Huntley had been a primary care physician in Warrenton, decided to leave his practice, come back and was a faculty member after working with Appalachian a couple of years. Dr. Carl Lyle was chief resident when I was a senior student at Chapel Hill Medical School. Bob Shaw had been the director of an Eskimo health center in Alaska. He had returned to Chapel Hill and was part-time faculty as well. John Payne became the administrator, and that was the staff of the division during the first couple of years. Important things about the division, very important, were Carl Lyle in particular was an accredited pilot. He was able to get a donor in Charlotte to provide the money for the first plane. They bought a Cessna push-pull, propeller in the front, propeller in the back, and that was the first beginning of the University Air Force. Carl remained the only pilot for the first year, and then Colonel Earl Provantia, who retired from the Air Force, he had piloted. The early activities of the division were concerned primarily with developing hospital affiliations. The second area was in Wilmington. The first real relationship that was developed for outreach with the hospital resulted in a training program that was jointly between the two places. It was Cone Hospital in Greensboro. In '67, Dr. Martha Sharpless and Dr. Bill Herring, they both went to Greensboro and became the first faculty members and to develop the teaching program there. And within just a few years, they had a full complement of residents, began to develop other residencies, a much larger faculty component in Greensboro. When I reached my third year in medical school, I had entered medical school with an interest in being a primary care physician who could go into the community and take care of the whole family on par with whoever else was out there practicing medicine. And I didn't want to be a partially trained physician. I wanted to be carefully trained. So I went to Dr. Charles Burnett, who was chairman of the Department of Internal Medicine at the time, and presented my dilemma to him. And Dr. Burnett said, well, you know, son, we are concerned about that, and we have been concerned for some time because we see lots of young men coming in want to take this track as their primary path, but they don't have a training program. So you got three choices. And I said, what are they? He said, number one, you can quit. And I said, I don't want to do that. He said, you can pigeonhole yourself in a narrow special and you'll probably be unhappy by the time you're 45 years of age. And then he said, oh, you can tailor something the way you want it and make your own program. And I said, well, what do you have in mind? He said, we came up with the decision that any future primary care physician should be extremely well trained in both internal medicine and pediatrics primarily. We've had the mixed internship that provided 6 months of medicine and 6 months of pediatrics, but nobody's wanted to go beyond that. They veer off at that point because they're worried about board certification and they're worried about socialized medicine coming in and not being certified and not being recognized properly, and so they go off into other areas. Would you be interested in doing that? And I said, how am I going to get specialty boards? He said, well, if you finish both of these residencies and they don't recognize you with the opportunity to take the examination, they'll deny you over my dead body. And I said, well, that sounds good enough to me. I think that's what I'll do. So I took a year and a half training in internal medicine and then the second year is pediatrics. At that time, we had to either risk being drafted out of the residency or either we could get a 2-year deferment with what was called the Berry Plan. And after that 2 years, we go into service for 2 years to pay back the obligation. I came back to Chapel Hill in '64, and at that time the division was being created, and Dr. Berryhill gave me the opportunity to be part of the division. And I attended meetings with him as often as I could. I came to the conclusion that what I wanted to do was to develop a model for primary care. And I had read about what was being done at the University of Colorado with the training of nurse practitioners. And I thought what should be done was to develop primary care practices where you had someone well-trained in internal medicine and pediatrics with extenders. The ideal, I thought, was a rural practice where you could develop a group that could support each other and work together in providing care to a community and could expand by employing mid-level practitioners as well. Dr. Cecil Sheps, who became the first director, provided me support. Everywhere I went, they didn't know what to do with me because I was trained in both internal medicine and pediatrics. They wanted me to do one or the other. Tara was the first place I found that they would allow me to do it. And I'm talking about all this because this was the reason there was a third AHEC, and it was a truly rural AHEC in Tarboro. There's a very close correlation between where medical trainees take their residency and where they practice. There's not a very close correlation between where they go to medical school and where they practice. And so when I went to Tarboro, I set up a Department of Medical Education in Edgecombe General Hospital in Tarboro. Dr. Wood came down and arranged professors from Duke and Chapel Hill to come on rotation to put on a training program to help train the doctors, myself included, all of us in Tarboro, to be able to take care of those problems. We also began to have student rotations, and we had residence rotations, 1-month rotations for residents and longer. Robert Smith, Dr. Berryhill had recruited from Guy's Hospital in England. He had developed a course in human ecology and had asked me to connect with him every Friday, and he would tell me what he was talking about in the classroom, and then I would relate that to what I was seeing in the office that day. And after the first couple of years, we decided it'd be better to fly the students to Tarboro and have a seminar for them there. And so for 15 years, we had the entire freshman class, UNC School of Medicine, 4 at a time on Friday, were flown to Tarboro. We first had a seminar on community medicine, took them through the system, and then turned them over to the doctor who was seeing patients that afternoon so that they could see and relate to what's going on in the community. In 1969, what I would like to call the second half of the Flexner Report was published. That report was higher education in the nation's health. They looked at the condition of healthcare in the United States at that particular time and came up with recommendations. And the major recommendation they made was bring education out of the community into the university. If you want to redistribute healthcare and get it in the mainstream of delivery and out where people need it, then you need to redistribute medical education, get it out into the communities so that you can encourage young practitioners to go there. Legislation was passed after that report came out by the United States Congress. In '72, the AHEC program began after University of North Carolina was chosen as one of the sites for the first area health education center programs in the country. After that, we had even more students to come out. Our staff grew. We had more residents and students coming, and other communities in eastern North Carolina had begun to work on activities as well. When AHEC became a possibility, our development out here and the development in Wilmington and the development in Charlotte and the relationships there put us all in a natural place to become the first 3 AHECs. The changes that have come about as a result of AHEC are too numerous to count. AHEC across the state did what needed to be done to get doctors out. That's really the past history of AHEC, and since that time, other people will have to tell you what has happened.